Okay. All right. So the control of this. So we talked about the different causes of pH and CO2 changes and bicarb changes. Now, how do you change these things? How do you fix it? All right. What's almost like the treatment of these things, right? How does your body treat it at least before we have to step in and add some steps? Okay. So the quickest and fastest thing is our lungs. Our lungs can exhale CO2. They can get rid of CO2. Even though you have a metabolic acidosis, if you get rid of CO2, which is an acid or base? No, CO2 is a acid, right? So if we're getting you were using up a bicarb here, right? You've used up 2 bicarbs, let's say, and let's get rid of 2 CO2s. Bam, now we're evenish, sort of. Didn't really do that right. Anyways, we'll play with that later. Anyways, you're going to blow off CO2. That's going to make you more balanced, right? So your respirations are a way to quickly fix an acidotic situation, right? A metabolic acidosis situation or a respiratory acidosis situation? No, a metabolic acidosis. When you have metabolic acidosis, your body is going to respond by breathing faster to balance this out. It's going to blow off CO2. It's like, hey, you have too much acid. Let me get rid of acid and let's balance this thing out, right? So we have ways to sense at all times what our O2, CO2, and pH levels are. All right. In our brain, we have central chemoreceptors. They're always detecting pH and CO2 levels, right? pH being the optimal one. So if you have metabolic acidosis, the pH is what? Low or high? It's low. We have low pH and acidosis situations, including metabolic acidosis, right? We have low pH. The brain's like, oh shoot, pH low. What do I do, right? And it knows exactly what to do. It goes to the hypothalamus. It goes to the medulla, and it says, I know how to fix this. We have something called the autonomic nervous system, right? We have the ANS, which has an accelerator and brake. And now the medulla is going to decide, do I need more brake or more accelerator? And which one do you need? More accelerator. And the accelerator is going to, yes, raise the heart rate, but more importantly, it's going to raise the respiration per minute, right? It actually makes you a deeper tidal volume as well. You're going to blow off a lot more CO2 to fix a metabolic acidosis to balance this out, okay? And then the kidneys, they work very, very slow. The kidneys they will fix an acidotic or alkalotic situation. And just to backtrack, your lungs can go the opposite direction. When you have metabolic alkalosis, they can start breathing slower. So let's try to add what? Add CO2 to the equation, because you are gaining what? You're gaining bicarb, right? In metabolic alkalosis. And I'd say, well, let me add some more CO2, and that will even us out, right? So you can breathe slower in metabolic alkalosis. All right, then the kidneys. So the kidneys are very, very slow. They take about 18 hours to get underway. And they can excrete bicarb if you have too much bicarb. They can excrete hydrogen ions if you have too much hydrogen ions, and they can balance this, right? So they can, because usually bicarb is what neutralizes hydrogen ions, but you don't want to have the kidneys just use bicarb, right? So what they do is they actually break down an amino acid called glutamate, right? There's 20 amino acids. Everybody know they're called 20? There's 20 of them. So you have 20 amino acids, and one of them is glutamate, all right? And glutamate can be broken apart and then attached to a hydrogen ion, right? All amino acids have what in the chemical structure? An amine, an NH2, right? So the NH2 binds to H, and now you got NH3, right? So that's going to get excreted as ammonia. That's why your urine smells like ammonia or NH3. All right, anyways, blood is our last way to fix an acid-base imbalance within our body. And our blood is going to work really fast, and it's just temporizing. The actual way to get rid of CO2 or get rid of bicarb is going to be our respirations, our lungs, or our kidneys. But in the meantime, we can hide it, right? Because what happens if our pH is too low? What if we have hydrogen ion excess? What lethal rhythm are we at risk for? All the lethal rhythms, right? Torsades, VTAC, asystole, polymorphic VTAC, which is torsades, right? VFib. Those are all, remember H's and T's? Hydrogen ion excess is a reason for it, right? So we want to stabilize our bloodstream. We want to make sure our bloodstream's pH is what? 735 to 745, right? Make sure that it is good, right? And when it's good, then our heart can function, right? Our heart can actually beat. The actin myosin can then be displaced. The sarcoplasmic reticula can hold on to calcium, because if it doesn't, you're going to have cardiac standstill, right? So all those little proteins are there in place to make sure that our heart keeps contracting, right? What if we're too acidotic and our heart cannot contract, but you still see electrical activity on the screen? What's that called? Pulseless electrical activity, because the pH is denaturing the proteins to the point where they cannot function, right? So you have pulseless electrical activity when you have too many H's, right? So the blood can make sure that doesn't happen by stabilizing that, right? It's going to say, hey, your H's are way too high. Let's go and shift them under the table for you, right? We're going to put them into the tissues until your kidneys can fire back up and until you can start breathing again. Then we'll exchange later, and we'll then finally blow off those extra hydrogen ions, right? And those hydrogen ions exchange with potassium, and they go back and forth. You can, if your potassium is high, you can exchange that with hydrogen ions, because is it bad if your potassium's high? That's also cause for bradycardia and PEA and other bad lethal rhythms, right? So your body's smart about it. It says, hey, we're going to keep your K optimal and keep your hydrogen ions optimal, right? Until you can actually fix it with your kidneys or lungs, okay? So H and the K can switch places, right? So we have every little cell kind of like a representation of our cells. H's and K's will switch places, right? And they will do it based on pH or potassium levels. They will make sure everything's good, right? So that's why when you have too much potassium, it's going to exchange with what? Hydrogen ions, right? It can exchange with something else that's positively charged. What else is positively charged in the body? Sodium, yeah, you can exchange with sodium. If you give someone 3% saline, their potassium level will go down, okay? Or it will fix that. All right, so how do we fix our, other ways we fix hyperkalemia usually is with insulin and beta agonists. They will push potassium into the cells, and that's one of our fixes for someone's hyperkalemic. In the meantime, they will exchange hydrogen ions. You'll get acidotic when you're hyperkalemic, right? Because say, hey, you have too much potassium around. Let me fix that temporarily, but put the potassium into the cells and put the hydrogen ions outside in the bloodstream, right? Until we can fix that. And then you say, well, let me fix that with some insulin. We'll give them insulin, or we'll give them beta agonists to push potassium into the cells, and then the hydrogen, and that will fix our problem. Okay? And then alkalosis for the same reason. When we're alkalotic, it's like, oh, you're way too alkalotic. How are we going to fix that? Well, let's exchange it with potassium. Let's put the hydrogen ions in the cells outside into the bloodstream, right? And now the potassium could go into the cells. So our potassium level in the bloodstream is now low, right? So they go the same way. Hyperkalemia is acidosis. Hypokalemia is alkalosis. And we'll explain that again. There's another slide dedicated to this. All right. So what is it now? What happened? There we go. All right. So we'll talk the respiratory component, and then we'll take a break after the respiratory component. All right, so it's kind of on the same path. We're talking about O2 and CO2. When there are two different ships in the night, they don't interact, right? But yes, when your oxygen level is low, you will breathe faster and you will blow off more CO2. But it really they're not related to each other, okay? So O2 and CO2 are the responsibility of the lungs, and you blow off more O2 and CO2, or you bring in more O2 and you blow off more CO2 when you have an increased respiratory rate, and we have an increased volume of air with each tide, each tide of the ocean, each breath you take, right? That's going to bring in more oxygen and also exhale more CO2, okay? And we can calculate how much that is per minute. That's called our minute ventilation. Minute ventilation is how much volume with each tide, which is about 500 cc's, compared to how fast we breathe per minute. If we're breathing really, really slow, that leads to respiratory what? Respiratory acidosis, right? So decreased respiratory rate or hypoventilation will build up CO2, lowering the pH, making us get respiratory acidosis, right? And then what if we're breathing super fast? We're going to have a what? ABG imbalance. We have increased respiratory rate, or otherwise known as hyperventilation, right? And our CO2 is going to be very, very low. So we can fix that by saying, hey, don't exhale your CO2. And how do you tell someone not to exhale their CO2? You can breathe into a bag. You can rebreathe it, right? You can recycle it, right? You breathe into a bag or put a non-rebreather on them. They don't need oxygen at this point. Just turn off the oxygen and put a non-rebreather on their face, and that will rebreathe the CO2. Okay? So respiratory rate, why does the respiratory rate go up or down? That's based on the SNS, right? So the reason why someone might have respiratory, if someone's breathing, if you have an SNS response, would that result in a respiratory alkalosis or respiratory acidosis if you have a SNS response? It's result in a respiratory alkalosis because our response, when we have an SNS firing off, we're going to be breathing faster, right? What makes you breathe faster? Well, these are also the causes for respiratory alkalosis, right? Someone's hypoxic, someone has a low pH, someone has a high CO2, someone has a low blood pressure, right? Someone has a low blood sugar, right? Someone is stressed, has infection, fever, pain, right? Those are going to trigger the SNS, and you can develop respiratory alkalosis, right? And just straight up movement. If you move someone in the bed, you start moving their knee, they're going to start breathing faster, all right? To the point of respiratory alkalosis, probably not, but someone is like running a marathon. After the marathon, they're probably going to have what ABG imbalance? Depends on how fit they were. They might have some lactic acidosis, but usually someone is fit and runs a marathon, or if you just run up the stairs like I do every morning, you're out of breath, right? Or like I run like three stairs, I think. Anyway, so if you run up the stairs, then you get you're breathing what? Fast or slow? You're breathing fast, right? That could be hypoxia, that's not good, or it could just be straight up movement, right? So these are the, your ANS gets stimulated by all these things here, and the way it knows is there's little chemoreceptors out in the periphery. There's CO2 chemoreceptors, pH ones, all these different receptors that detect these incoming inputs, okay? So what else? So that's where they're located. Your CO2 and pH is in the brain. Your O2 is out in the periphery. There's testing the waters right outside the heart, because if right outside the heart has low oxygen, you probably have low oxygen elsewhere in the body, including the brain. Okay, pH is usually the highest determinant. That's really bad because it's going to mess up everything. So when that pH starts getting low or high, your SNS is going to fire off real quick. And is it going to fire off? When would the SNS fire off? Low pH or high pH? Low pH, right? All right, so let's come back for the kidneys. All right, so we talked about the lungs, right? So our lungs can get rid of, can balance our pH, right? What else can balance our pH besides the lungs? The kidneys, and what's the third thing that can balance our pH? The what? The cells, right? The cells can exchange hydrogen ions with our bloodstream, right? So to maintain our pH at 7.35 to 7.45. So our lungs will do that, and so will our kidneys, right? So 7.35 to 7.45. If you have excess amount of carbonic acid, right, you're just going to pee it out. That's as simple as that. We're going to take the H2CO3, the hydrogen ions and bicarbs, and we're just going to pee it out as carbonic acid, right? That's all we're going to do. Okay, and then if we have excess, if we want to, the whole way this happens, if we have a lot of acid, we can take extra water and CO2 from the bloodstream and from the tubule inside the kidneys, and we can combine it and then get more bicarb and hydrogen ions to expel. I don't know, I got a southern accent all of a sudden. And then we can then reabsorb the bicarb if we want to, right? You can see right here, we take a water and a CO2. We form carbonic acid. The hydrogen ion binds with another CO2, right? And then we now get, and then we're left with bicarb that can then get reabsorbed. And now we can salvage bicarb and stabilize someone who has an acidotic situation, okay? And so acidotic, we just excrete excess hydrogen ions as well. Another way to fix this is we have too many hydrogen ions. We mentioned we can break down an amino acid, specifically glutamate. Right, so we deaminate it, and an amine group is NH2. So we take away and we convert it into ammonia as well, and then we can then bind it with a sodium chloride. Right, sodium will then get reabsorbed, so will bicarb, and then the chloride binds with the ammonium, and now we get pee out extra hydrogen ions. So in acidotic conditions, you can do that. And what about alkalotic conditions? So alkalotic conditions, you have to get rid of what? Bicarb, right? So we just pee out sodium bicarb. We're not going to hold on to anything. Like the other two situations, we held on to the bicarb, right? Or we held on to the sodium so we can then reabsorb bicarb. Okay? In metabolic alkalosis, the most common reason for metabolic alkalosis is someone who's taken potassium wasting diuretics. If you waste potassium, are you hyper or hypokalemic? You're hypokalemic, right? You have less potassium around, right? Less potassium around makes the heart what? What happens to the heart and EKG stuff when you're hypokalemic? You're not so much tachy, but at risk for tachy, like at risk for PSVT, at risk for AFib, at risk for VTAC, at risk for PVCs, at risk for PACs, right? You're at risk for ectopy. You're very, very close to threshold, and you're able to, anything that will put you over the edge to then have abnormal impulses, right? So that's not good. So your body knows that. So it's going to change your potassium level. How does it change your potassium level? It's going to put the K into the blood and put the hydrogen ions where? Sorry, I said it backwards. And so if you're hypokalemic, yes, I guess it goes both ways. That's why it can be confusing. If you're hypokalemic, you're going to take the K from the cells and put it in the bloodstream, and the hydrogen ions will go into the cells. So now you become alkalotic. But what if you peed out all the K? You're going to become even more alkalotic, aren't you? Because now you're hypokalemic. We're going to take the K from the cells, put it in the tissue, take the hydrogen ions from the blood, and put it in the cells. Yes, you get alkalotic, but our K is balanced, and we don't have problems with our heart, right? So that's the idea. That's what your body's doing. It's trying to stabilize potassium and hydrogen at all times. Okay, so you get this alkalotic situation when you are peeing out all your potassium. So you say, well, I need to hold on to that. So you get really, really alkalotic when you pee out potassium. What if you take a potassium-sparing diuretic, right? Your potassium is spared, meaning that it reabsorbs from the urine and gets placed back into the bloodstream, right? Or there's a process that's blocked that doesn't let you get rid of potassium, right? There's only one hormone in the body that gets rid of potassium. What hormone is that? Aldosterone, right? So we have diuretics that block aldosterone function, right? What does aldosterone do? It gets rid of, it reabsorbs sodium from the urine, puts it back in the bloodstream, so then water follows and it restores your blood pressure. Well, what if we don't want extra water or extra blood pressure? We want to get rid of water and blood pressure. So we give medication that blocks that process. You give aldosterone, an aldosterone antagonist, right? So spironolactone and eplerenone are examples of aldosterone antagonists, right? And they will then make you diurese, but then your potassium level goes up. If your potassium level goes up, is that good for the heart? It doesn't like that. So what it's going to do is it's going to put the K from the bloodstream into the cells, and from the cells, the hydrogen ion is going to go in the bloodstream. So you get what? Acidotic, right? So K and hydrogen ions will exchange to make sure that our body's maintaining neutrality. Okay, so potassium-sparing diuretics, like I mentioned before, there's only 4 of them, and everything else is potassium wasting. So all you got to learn is the ones that are potassium-sparing, and everything else is going to waste potassium, and everything else puts you at risk for metabolic what? Alkalosis. Okay, so the 4 that are going to retain potassium are S and E, I already mentioned, were spironolactone and eplerenone. So the mnemonic is SEAT, all right? And amiloride and triamterone are barely used anymore, but those are the 4 possible medications that will retain potassium, okay? There's one other diuretic that it's not potassium sparing, but it will acidify the blood, right? Because those SEAT diuretics will acidify the blood, right? Because they retain potassium. Someone's not paying attention. They're just passing meds like med slingers every morning, right? They're passing 10 meds here, 10 meds there. They're not paying attention to the potassium level. That potassium level can creep up, and now the heart's like, well, the potassium level is too high, so the body will exchange the K, put it in the tissues in exchange for hydrogen ions, and you'll get acidotic, right? But there's another medication called acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor, and it's typically used when someone got too much K-wasting diuretics. What's an example of a K-wasting diuretic? Furosemide, bumetanide, thiazides. There's all kinds of diuretics that are not SEAT, will waste potassium. You get metabolic alkalosis. That means your bicarb is high or low. It means your bicarb is high, right? And why is the bicarb high? Well, A, we reduce the concentration of fluid, and then the bicarb is the concentration is ultimately going to go up, but also you're wasting potassium, right? The potassium is getting lost, and then your body's going to respond with the RAS system to try to fix it. But either way, you're going to have a hypokalemic state, right? And you're going to be in an alkalotic state. So how do you fix that? We can give acetazolamide, and that's acetazolamide acidifies the blood, right? It doesn't acidify the urine, it acidifies the blood. The way it works is right there, right? It's going to stop that whole process of making hydrogen ions, and getting rid of them. Instead, the hydrogen ions are not going to get rid of. They're just going to stay behind, and you're going to get acidotic in the bloodstream. Right? So acetazolamide is a treatment for what? Metabolic alkalosis or metabolic acidosis? A treatment for metabolic alkalosis, especially if someone still needs diuretics. Right? Someone doesn't need the diuretic, stop it. Right? Don't keep giving the medication that's causing the metabolic alkalosis. Right? And then how do you know it's time to stop a diuretic? It's 12 o'clock on a Tuesday. How do you know? The urine output's good? How do you know it's good? How do you measure if someone has good urine output? The I's and O's, right? So the I's and O's are positive or negative? Would tell you they don't need diuretics anymore. No. If they're positive, they probably need to get rid of fluid and need diuretics. And they need to start acetazolamide because they're too alkalotic. So when do you know, so if the diuretic itself, like furosemide, Lasix, was causing someone to pee out way too much potassium, and then because they peed out way too much potassium, they became hypokalemic. And when you're hypokalemic, you get alkalotic. You get respiratory alkalosis or metabolic alkalosis? You get metabolic alkalosis. It's like, well, why do they have metabolic alkalosis? You can look on your chemistry and see that the bicarb is 32, right? So you could say, well, what do I do? So, well, you can suggest that you can then tell the doctor, hey, the I's and O's are this. They probably don't need this diuretic anymore. Or the I's and O's are this. They still need a diuretic. What would you like? Because you know the answer. It should be acetazolamide, right? So the question was, would the I's and O's be positive or negative? Would tell you that you need diuresis or you don't need diuresis. Negative, right? If your I's and O's are negative, that means you're peeing out a lot more fluid than's coming in, right? Does that make sense? So that's application of I's and O's. So for your clinical instructor, when you're giving any diuretic, you just let them know, hey, their I's and O's, they're positive for the last 24 hours, or I should still give this medication, right? And then you can also look at the bicarb. It's like, well, I didn't do an ABG. Well, where's that bicarb at? It's right beneath the potassium, right? And what is it? What does it look like? It's under witness protection as a CO2, right? The CO2 in the chemistry is your bicarb, right? So those things tell you that it's safe to give the medication, right? Again, we're not med slingers, right? That's you're learning that the why behind these things so that you know that you're not going to cause the patient more problems. Because what's the potential complication that can happen? Well, they just get dehydrated. They'll just drink some water, it'll be fine. But what can happen? They can have VTAC, or isn't one of your H's and T's? What's H is hyperkalemia and hypokalemia, right? I had a patient that we ran up to the second floor because the patient was in a cardiac arrest, and they said, "What happened?" No one could figure out what happened. I said, "What about this? All I did was give Lasix this morning at 6. Well, what was your potassium level? Oh, it was 3.1 yesterday. Well, shoot, they've been getting Lasix all day, and they've been peeing out so much that if you gave Lasix, it's probably 2.8, and you gave Lasix, it's probably pee out more potassium, and they were in cardiac arrest because of the hypokalemia. Right? They went into VTAC arrest because of that, right? So you should be checking before you give medications because 6 a.m. time to go, right? Here, bye-bye, right? So you have to make sure it's safe to give these medications. Okay. So acidosis. So we're switching gears. Okay. So acidosis, how do you fix acidosis? What would happen, I guess what would happen as a result of acidosis is one thing is your anion gap goes up. So we have a whole slide dedicated to anion gap because it can be confusing, right? It uses math, like not complex math, like plus and minus, right? So you're calculating how bad is their acidosis with an anion gap, right? Because they have a whole bunch of acids that are built up, right? You can't always measure acids. Like you have really, really high acids. How much? You have like 36 of them. We don't really know. So you don't really measure acids in the bloodstream, right? You won't say, hey, your acid level is this, right? You can measure your pH, and the acid is causing that pH to be affected. But we use the anion gap to measure the gap in our measurements, right? We know there's this many ions pluses, there's this many minuses. If I add a whole bunch of pluses to that equation, the number is going to go up. Right, so that's called the anion gap. So usual is 12, and we'll talk about why it's 12. But to measure how bad someone's acidosis is, you can measure the anion gap. Anion gap at 12, not bad. anion gap of 36, pretty bad. That they have a lot of acids circulating in their bloodstream. Okay, so hyperkalemia is also an important result of acidosis. So someone's acidotic. How would you know they're acidotic? You can look at the chemistry, right? You can see, hey, on their chemistry, look at their bicarb in the chemistry is 12, and what their K is 6.5. What's the reason? Well, it could be the hyperkalemia alone, like they're getting too many potassium-sparing diuretics, or they're getting too much of a cardiac medication that might be raising the potassium, or it could be the acidosis itself that caused it, right? So there's other reasons for the hyperkalemia. But when you're acidotic, when your hydrogen ions are high or low, you have too many hydrogen ions, your body says, well, I can fix that. Let's put the hydrogen ions into the cell, right? And exchange them for potassium. All right, so if we have here's our cell right here, here's our bloodstream, we're gonna take the hydrogen ions and put them, we're really acidotic, let's put them in the cell and take the K and put it outside the cell. So we become hyperkalemic when we're acidotic. And it works vice versa. When you're hyperkalemic, you have really, really high potassium, heart doesn't like that, say, hey, put that K back in the cells in exchange for hydrogen ions. And the kidneys will kick in and hopefully get rid of those hydrogen ions later. But what if you're in kidney failure? That's why you end up in the ICU, because you have two problems at once, right? Yes, you're hyperkalemic, but your kidneys don't work, because that was the deal, right? You're hyperkalemic. Well, let's put the hydrogen ions in the serum, and the kidneys will pee it out. It's like, kidneys, you ready? And then nobody's home. So that's the problem. Okay. So life-threatening hyperkalemia, that's when it's greater than 5 usually. Greater than 6.5 is really a problem. Usually you don't survive when your K is greater than 9 unless you're a dialysis patient. Dialysis patients are used to having 9 lives, and they work at it. But someone like us who aren't in kidney failure, if our K goes to 9 right away, we're dead. Okay. So we want to not be dead. So how do you fix deadness, or how do you fix hyperkalemia? Yes, it's a better way to say that. If someone is dying from hyperkalemia, how do you fix it? We got to put the potassium into the cells, right? So we push temporarily the potassium into the cells, right, to fix the hyperkalemia that's causing problems. If it's causing EKG problems, such as what? PEA, asystole, all those bad lethal rhythms. We remember our H's and T's are for every lethal rhythm. And those H's and T's are reversible. So we can fix those right now, right? And someone's coding from hyperkalemia, they can say, hey, they're in a kidney failure and they're acidotic this morning, and now they're coding. It's like, well, let's give them some treatment for hyperkalemia. And what is that treatment? It's going to be calcium chloride. Calcium chloride or calcium gluconate. You're giving calcium to stabilize the cardiac membrane. Okay, so like calcium will stabilize the cardiac membrane. So anytime someone has EKG changes and hyperkalemia, is usually the first thing is that your response will be is give calcium. Okay, if the EKG is fine, then we can give these other agents right here. These other agents take time to work, 30 minutes, an hour, 4 hours, 8 hours to kick in to lower their potassium. They will work, but they're not going to work immediately to fix them. So calcium chloride doesn't actually change your K levels, doesn't make your K go from 7 to 6.5. All it does is like it's like a shield, right? It's like casting a spell. It's like, ooh, calcium chloride, right? And then it goes up and it stabilizes the cardiac membrane, so your heart can actually contract and depolarize, right? So the calcium chloride and calcium gluconate, one's weaker than the other. The one that's found in the crash cart when someone's coding, the crash cart's in red there, that's the one that's going to be the strongest. So CC is in the CC. So calcium chloride's in the crash cart. All right, that's the strongest one. Okay, so then you have other ones that sweep the potassium under the rug, like Mr. Clean right there, right? All they're doing is they are pushing the potassium into the cells, right? So here's our basic illustration of how that works, right? K goes in when glucose goes in, and also when insulin goes in, and also when you attach to a beta receptor. All those things will put potassium from the serum into the cell. So how does that specifically work? So like a insulin, right? Attaches to the cell, lets glucose in, and who hitches the ride? Potassium. All right. So K is always hitching a ride, right? But it's not really on the same side. It's easier to think it's just hitches a ride, but really it's going to the back half of the membrane, and then it's allowing potassium in. It does some fancy behind the scenes things. Eventually, when insulin or glucose or beta receptors is stimulated, the doorbell is hit, then the K is going to go into the cell. Okay, so we can manipulate that. We can give someone insulin, right? So we give someone insulin that will lower their potassium by a certain bit, like by 0.3 or 0.5 or so. All right? You usually give some insulin, and this insulin you give IV, right? And what kind of insulin is the only insulin you give IV? That's regular insulin. It's like, well, isn't all insulin regular? You'll find out soon enough. There's like 8 different insulins, right? So regular insulin is the only one that can be given IV. And then we give dextrose, because when you give insulin, what happens to the sugar level? It goes down. So it's probably a good idea to give dextrose, right? So that you don't have another H on your hand, another hypoglycemia that can cause a cardiac arrest. Okay, and then a beta agonist. This works over 4 hours, right? So they have a breathing treatment. A beta agonist opens up the airways, but it's not because you're opening the airways. You're trying to lower the potassium level. All right, and then bicarb, right? Bicarb is going to be used to. It makes sense if you give bicarb. That's in their acidotic. That matches up, right? That should work. It doesn't. All right, so bicarb push is a antiquated thing. It's been disproven many, many times. You should never give bicarb during a cardiac arrest unless they overdose from an antidepressant. That's really the only reason why you should be doing it. We'll do it just for funsies when the pH is really, really low or the bicarb is really, really low. But actually, when you give bicarb IV push, it actually raises the potassium. All right, so bicarb is so osmotically active, like we talked about in central lines, right? It's so osmotically active, it's like 800 to 2,000, right? It's going to pull everything with it, including potassium, into the serum. So it's actually going to raise your potassium by like 0.2, 0.3 points when you give bicarb IV push. Okay?
Bicarb isn't going to be one treatment?
I'm not going to test you on it. I mean, when you take the Kaplan or you take your other ATI or take the NCLEX, you got to be wary. It's like, well, is it like officially? Should I give it? I don't test you on controversial things, but I just want you to know what the right answer is, right? In like in real life in a hospital setting. But will the NCLEX test you on it? They probably won't test you on something that's controversial either. So they don't, they try to do things that are solidified, things that we know 100% are true. Yes.
So to control the hyperkalemia, you would give all of those listed medications?
Yeah, you can hit them. You can throw the kitchen sink at them.
Okay.
Yeah. You hit them. You throw everything at them. Okay. So just to bring down the potassium. All right. And then of course you're going to check your work to make sure the potassium level is not too low. Then that's now you have hypokalemia, right? So after you give it like a whole round, they call it a cocktail, literally like a COCK, right? With a K cocktail is given for someone that has high potassium, and then they check their work with the chemistry to see is everything better. Okay. So all these guys just sweep the potassium under the rug, and then we have ways to pee it out if their urine system, if their kidney system works, then you can pee it out. That's called caluresis. So K stands for potassium, uresis means pee it out, right? So we give what? Potassium sparing or potassium wasting diuretic? Potassium wasting diuretic, that would make sense, right? So furosemide is usually our go-to. And then we have a GI system. The only way potassium gets into your body is through your GI tract, right? So we give medications to poo out the potassium. And that's a definitive way to get rid of potassium. Either pee it out or poop it out, or slurp it out of the bloodstream. How do you slurp potassium out of someone's bloodstream? You slap a membrane on one side of it, you take it out of their body at 600 mLs per minute, and then you dialyze it. That's what dialysis is, all right? So it goes from high to low. The dialysate is like 2K. Their K is 8K, and then now goes from 8 to 2. And now you've taken out their potassium. So definitive treatment is taking it out of the blood with hemodialysis, but you need access, right? Like immediately right now, someone's in cardiac arrest, you're not going to set up for dialysis, right? That's going to take a second, realistically. But if they have dialysis access and they're stable, let's set up for dialysis, right? But if they're unstable, we're going to stabilize the membrane with calcium, hit them up with the other medication, the cocktail, and then while dialysis is coming, to ultimately get it taken care of. But then what kind of access do you need for dialysis? Like temporarily? Yeah, officially it takes 6 weeks to mature. So like, okay, we're gonna put you for officially. You go to surgery, 6 weeks we'll take out the potassium. No, it's gonna do, or about a permacath. No, that's too much involved, because permacaths are for patients that have like permanent dialysis, right? Or permanent kidney failure. Hopefully this is temporary, right? And then we can just do what kind of central line? A VAS cath, right? A vascular catheter for dialysis, which is a temporary catheter. Lasts how many days? About 21 days or so. Okay. So going back to pooping it out, traditionally we give Kxalate, right? Sodium polystyrene sulfonate. is the generic name, SPS, but it's no longer recommended. It's been no longer recommended for like 11 years now, right? You should never give it because it causes GI obstruction and megacolon is not good, but you'll still see it given, all right? Because those doctors were trained back when KXLA was popular, okay? But it takes people to be on committees and other things to make sure that we're doing the right thing for the patients. But you'll see some patients on Localma as the brand name, or sodium zirconium. It's like what you buy your girlfriend at Kay's Jewelers, right? So you buy some sodium zirconium. It's going to lower your potassium, babe. All right. So anyways, then also we got patiramir is another one that's usually used for dialysis patients. Okay. So these are all medications you give for someone that's hyperkalemic. Okay. All right. So anion gaps. So anion gap again is the measure. It's only used for one ABG disorder, and the ABG disorder is metabolic acidosis, right? It measures how bad someone's metabolic acidosis is, okay? So what is a normal anion gap? So when it's elevated, they probably have metabolic acidosis, right? But what is a normal what is a normal anion gap? Anions are negatively charged molecules. Cations are positively charged, right? So in your bloodstream at any one time, you have a certain charge in your bloodstream, like because the positive negatives are one side at all times, right? But also we have sodium floating around, you got chloride floating around, you got bicarb floating around. All right, these all have positive negative charges, right? What's a normal sodium level? 135 to 145. What's a normal chloride level? 95 to 105-ish, right? And then what's a normal bicarb? 22, 26, right? And then what's normal potassium? 3.5 to 5, right? What's normal mag? 2-ish. So now we're getting to insignificant cations, insignificant anions, right? So the really more significant ones that we're going to calculate are sodium, bicarb, and chloride. And the rest are 12, right? So if we take 140, right? You subtract bicarb, you subtract chloride, you get a value of about 12, right? That's all the ions that are there are 12, right? And now if you add something to this equation, like adding acids, that's a positive number, that's going to make it higher, right? That's called a high anion gap metabolic acidosis. And it makes sense. We have acids that get added. What kind of acids? Acids that will kill you, right? So we add ketones, right? We have keto acids that could get added. We have lactate that could get added. We have renal failure that leads to hyperkalemia. And also we can't get rid of the acid itself, and that causes these acids to build up. So literally we're adding acids to the equation, right? So let's say about 10-ish, right? And because you added 10 acids, you probably subtracted some bicarb, right? Because the bicarb neutralized it. And if you add all those numbers up, you get about 36, right? So we have all these acids that are built up in the bloodstream. So they have a high anion gap metabolic acidosis. And like when we talk about DKA, the way we know someone's no longer in DKA is their anion gap's normal. Well, how do we know they're no longer in DKA? Because DKA means the production of ketones. If you're not producing ketones, those ketones are not going to add to the equation. Okay? So that's called a HAGMA, or a high anion gap metabolic acidosis, when you're adding acids to the patient, right? And if you do the math, all right, 140 minus 24 minus 104 is about 12-ish with all the other different cations and anions. And now we see this is 0. You shouldn't have acids at baseline, right? The second line there. So we should have 0 acids at baseline. But what if we add 10 acids, right? Drop 10 acids. You're going to bring down the bicarb, right? Because the bicarb is going to neutralize. And then that's going to equal about 36, approximately. And that can range anywhere. As it's greater than 12, you have a HAGMA. You have a high anion gap metabolic acidosis. It gets tricky when you talk about NAGMA, which is a normal anion gap metabolic acidosis. That's where they're acidotic. They have metabolic acidosis. How do you know they have metabolic acidosis? The pH is low and the bicarb is low. Why is the bicarb low? Well, it wasn't because they were neutralizing an acid. It's because they were pooping out their acid, right? So the bicarb is leaving. So if you look at your equation, we've got 140 minus the bicarb. Well, we got less bicarb now because we pooped it out, right? So we got 140 minus 15 due to diarrhea. We pooped out 10 bicarbs, right? And we are going to be, we didn't add acids to this, but why did the chloride go up? Well, your body needs to make, like you heard of midichlorians, right? So they're real. So midichlorians are what measure your force within your body. Your force is about +3 to +12. And to maintain that force at all times, the force that goes in and around us and surrounds all things, right? So that force needs to be neutralized at all times. So if you lost bicarb, your body is now more negative, right? It lost all these negative stuff, right? It's actually more positive because you lost the negative, right? You're missing bicarb. So we got to add more negatives to the equation. So what do? We take the chlorides from the cell and put them into the bloodstream. So now your chlorides level is elevated because of that, right? So you'll notice someone that has diarrhea, their chloride level is high because they pooped out all the bicarb, and your body has to neutralize that somehow. It needs to maintain its force at all times, and you're going to have a elevated chloride. Yes?
Do you need us to commit this equation to memory?
No, you should recognize if it's high or low.
Okay.
Yeah. All right, and what causes it. So the other piece is, someone getting sodium chloride. So if you're giving sodium chloride to someone, like 0.9% sodium chloride, what's that going to do? You're adding chloride, and you're putting all this chloride in a serum. What does it say? There's, it's either the chloride or the bicarb. We got to maintain neutrality. So now the bicarb goes into the cells, right? Because the chloride's there until our kidneys can get rid of it. But that's one of the reasons why sodium chloride is not great to give to patients, because it causes metabolic acidosis, right? A normal anion gap metabolic acidosis. With?
So you put the chloride in the cell and then the bicarb leaves, right?
So we're putting sodium chloride is infused into the bloodstream. So you're putting all this chloride in the bloodstream, right?
How would it make it more acid?
Because the bicarb is going to leave the bloodstream and go into the cell now. So you become more acidotic because the bicarb that was the bloodstream, the chloride comes in. It's like, hey, I'm here, or we're new people in town. It's like, okay, one of us has to leave, right? And someone out there is giving 30 mLs per kilo of sodium chloride, right? So one of us has to leave. So what's going to happen? The chloride's going to go up, right? And then the bicarb has to leave and go into the cells. And since bicarb left, you didn't poop it out, but the bicarb left, and if you lose bicarb, that's called metabolic acidosis.
Chloride makes it more acidic.
Mm-hmm. Yes. All right, so that's the idea behind anion gaps. And we'll touch base on anion gaps again with DKA. All right, so this is our table that kind of summarizes everything we've been talking about. So we're going to kind of put it in perspective. So in blue there are our respiratory problems, because respiratory is blue. And then in orange we have metabolic issues, right? And so we can have respiratory acidosis or respiratory alkalosis. And you can have metabolic acidosis or metabolic acidosis, right? So where to start? So you got causes, symptoms, the treatment, and things you can do, right? Nursing interventions to think about and to be aware of, alert to. So the first row there is respiratory acidosis, right? So if you have respiratory acidosis, that means you're breathing fast or slow. Slow. So what causes you to breathe slow? It's either something that's your diaphragm's not working, right? Or someone made you not breathe, such as we got opiates here, right? So did you OD on something? Something that's a respiratory depressant, a benzo, an opiate, other things that might make you not breathe, right? So not breathing usually that's apneic, but before that it's hypoventilation, right? Hypoventilation is the cause of respiratory acidosis. What causes you to not ventilate, right? It could be, again, opiates. It could be a CNS lesion. In neuro, lesion means damage. So why can't you just say damage? It's like, well, because we're neuros, right? We're neuro people. It's lesion, right? So we have a lesion to the brain. We have damage to the brain. That can cause us to not breathe, right? What part of the brain controls breathing? That Steven Seagal hates? The medulla, right? When you crack the neck, right? Steven Seagal. So yeah, so if you have a neck injury that can crack the medulla, right? That's going to cause you to not breathe, or your medulla is not working. When else would your medulla not work? When it doesn't have the oxygen or blood flow to work, right? So this is the severe side of it, right? So it's like when you absolutely have a really, really low blood pressure or really, really low O2, that's when you can develop respiratory acidosis because your medulla is not working. It's not able to send this signal out to breathe, right? So a tired respiratory patient, someone super, super tired, that's someone that is going to not breathe well, right? So they were breathing super fast, right? They had respiratory alkalosis even, and they're breathing really, really fast, and then they're starting to tire out, right? Or someone has obstruction, right? Someone needs a Heimlich maneuver, or someone has asthma where their airways have closed off, right? That you're not exchanging CO2 anymore. CO2 is staying behind in the alveolus, and it's going to cause hypercapnia, right? It's cause a high CO2 level. All right, so CO2 production, that's again, you're talking about that more in Med-Surg 3 with thyroid issues. But we've skipped over neuromuscular. That's kind of neuro as well, but there's also there's CNS lesions in the brain. There's a problem in the brain or spinal cord, or there's a problem out in the periphery, right? Our diaphragm doesn't work, right? Or we have a myasthenia gravis or Guillain-Barré. We have all these different problems that are affecting our ability to breathe, right? Our diaphragm's not working well, right? These are all causes of us to hypoventilate, okay? So what are the symptoms of this? Well, if we have all these things here, you're going to have an SNS response. You're going to try to fix this. Are you going to breathe fast? No, because you can't. If you have probably something in the way that's not letting you breathe fast. But are they going to be tachycardic? Yeah. Are they going to be diaphoretic? Yeah. Are they going to have cool, clammy skin? Yes. So they will be like this, right? Late symptoms is when our medulla shuts off, and then you're going to have low heart rate. You're going to have low blood pressure. You're going to have comatose state. They're going to start getting worse off once you get to the end, right? So you have to think of this on a spectrum, on a line here, right? So if you have at the very, very end is coma and death, right? At the very end here is coma and death, right? And that's when the medulla shuts off. When the medulla shuts off, your heart rate goes down. Your blood pressure rate goes down. Your what else? Your breathing goes down, right? When you are at that point, right? So does a comatose person have hypoventilation? Yes, right? That also checks off. So how do you fix hypoventilation? How do you fix someone that is not breathing? You can breathe for them. How do you breathe for them? You put them on a mechanical ventilator, right? It's a mechanical ventilator and goes to ICU. And then in the ICU, they're going to play with the settings. They can play with the tidal volume, play with the respiratory rate, play with all those things. But our priority is like, are they protecting their airway? Do we need to actually put them on a ventilator? Or you can pull stuff out of your pocket. And what can you pull out of your pocket? Mm-hmm.
Wake up! Wake up! Wake up! Wake!
So you can pull out some naloxone and you can wake up the patient, right? Temporarily. You don't have to put them on a mechanical ventilator. All you have to do is, give them naloxone or reverse it, right? You only reverse certain things. What can you reverse with naloxone? Opiates. So a patient comes back from surgery, they got fentanyl in surgery, and they're on the floor and they're breathing really shallow, right? They're hypoventilating. The treatment is to A, wake them up, or B, you're going to say, we might have to give some naloxone, right? Or they might have got something else during surgery. What else would they have gotten during surgery that might make them not breathe? Anesthesia is a good one. You can't really, there's some reversals in anesthesia, but what else might they get? Sedation such as midazolam, right? Midazolam is Versed, and midazolam, all sedation causes hypotension, but all sedation also are narcotics, make you sleepy and not breathe, right? So you have to reverse that. How do you reverse benzos? It's Ozemba. No, it's romazicon, right? So romazicon is the reversal. It has a Z in it, which is nice, a Z for benzos, right? And then hypoxia. If they're like very, very hypoxic to the point where they're not breathing, they're like on the verge of coma and death, then yes, mechanical ventilation, but you might have to give them some oxygen. You might have to fix the situation, okay? What about interventions? What interventions would you do as a nurse, right? So you look for reversal agents for one, but also we're looking for things that aren't in the other columns, right? You're not going to assess respiratory rate, assess tidal volume, right? We kind of know that should be there. What are some specific things if you give reversal agents like flumazenil or like romazicon, I said the same thing, like flumazenil or like naloxone, these guys can make you at risk for seizures. So that's something to be alert to, okay, especially if someone has a seizure history. And then another thing to keep alert to is COPD patients, specifically emphysema ones, might have respiratory acidosis at baseline. That's what they live with, right? So we'll talk about that more when we talk about respiratory, okay? And then alkalosis, all right? So we have respiratory alkalosis. That means our pH is what? Greater than 745, right? So it's greater than 745. We have alkalosis, and what's caused that? CO2, that is what value? CO2 that is less than or greater than, which one? Less than 40, technically, yes, less than 40. 35 is really going to start causing some problems, right? So we got a CO2 less than 35. We have a pH that is high or low? High, right? We have respiratory alkalosis, right? So why do you have respiratory alkalosis? What are the causes of respiratory alkalosis, right? We have a low CO2 because we are hyperventilating, right? That's the most common reason. That's probably the only reason. This one's kind of pretty straightforward. I'm breathing too fast. Why are you breathing too fast? All right, you could have acidosis. Like, what does an acidosis cause? Hypoventilation? At the very, very end, it does. But all the way up until the very end, you're going to be breathing super fast until the acidosis gets to the point where you can no longer breathe fast because your medulla's protein is denatured, right? But up until like 1 to 8 on that scale of pH, or I guess that's a bad way to say it, but the first bit of when you're acidotic, you're going to be breathing super fast to try to fix it, right? And you're trying to fix that acidosis. This is like usually a metabolic acidosis. So you're breathing really, really fast to get to blow off CO2. Okay, so they have all this bicarb deficit. So they have all this acids building up. They're going to breathe super fast to try to fix it. Okay, well, isn't that metabolic acidosis then? There's overlap. So that's the thing to think about. Like, what came first? It's kind of, they have to think, well, where's the pH at, right? That's going to tell you which came first or what you're assessing. What if you're hypoxic? If you're hypoxic, your SNS fires off. Your SNS fires off. Your respiratory goes which direction? Respiratory rate goes up. So you have increased respiratory rate, which is hyperventilation. So really, these are all SNS triggers, right? So you got hypoxia due to a pneumonia, due to a pleural effusion, due to a pulmonary embolism, due to a pulmonary edema. All of these things are going to make me breathe faster until I get so hypoxic that I can't breathe anymore because my medulla is shut off, or I'm comatose. When I'm comatose, I'm not breathing. Now, that's why we say over there on the rightmost column, I guess we got some waves on the screen there, but you can tire out and develop respiratory acidosis, right? So we have all these causes. They can get severe enough where you can develop respiratory acidosis. Okay, going back over here, we got hypoxia, then we have activity and exercise, right? That can put you at risk for, or that will trigger an SNS response. And then just stress, anxiety, pain will also make your heart rate fast, but also make your respiratory rate fast. And your respiratory rate is fast, that's hyperventilation, right? So you have an SNS response as well. Well, how can it be in two categories? Well, this category is really where it starts, and then the other category is like it's kind of crying for help until it can no longer cry for help, and now you just get bradycardic, right? But when you talk about respiratory alkalosis, they're breathing fast, they're tachycardic, they're tachypnic, they have pupil dilation, they have cool clammy skin, they have all those things. And then also unique finding is they have circumoral paresthesia. That means their lips are numb. Okay, so how do you fix that? So you fix the underlying cause. If they have pain, fix the pain. If they have anxiety, fix the anxiety. If they have nursing school, fix the nursing school. Right? You have to do all those things to fix the underlying problem. If that doesn't work, you get a brown paper bag. Right? Get a brown paper bag where they can rebreathe the CO2 so that the CO2 does not get lost in the universe, right? The CO2 goes out their mouth and they inhale it back, right? To restore that diffusional balance. Also, we can throw a non-rebreather on them and turn off the oxygen. They don't need oxygen at this point, unless they are hypoxic. It depends. But if they just have like anxiety, then just non-rebreather without oxygen will be just fine, okay? You can give analgesics, you give antipsychotics, right? You can give benzos. What if you overdo it? Now you have respiratory acidosis, right? So you have to be careful. Okay. Monitor QTC for what? Antipsychotics. Antipsychotics are an important cause of prolonged QTC. Puts you at risk for what lethal rhythm? For torsades. All right, so we're switching gears to metabolic acidosis. All right, what causes metabolic acidosis are things that will kill you, right? Where you're adding acids to the equation, right? You have a hagma, right? You have all these acids that are building up. So you have ketones, ingestions, lactate, and renal failure. All these things will make you acidotic because you're adding acids. The other thing is hyperkalemia. When you're hyperkalemic, your body's like, well, I don't like that. Let's put the potassium from the bloodstream into the cells, and that will then, what are you taking from the cells? You have to maintain electrochemical neutrality at all times. K plus goes in, H plus comes out, and you get acidotic. All right. So the other piece are GI, right? So GI wise, are you going to poop out bicarb or are you going to vomit bicarb? You poop out bicarb. You have diarrhea. That's going to cause metabolic acidosis. Right? Other thing is excessive sodium chloride, like we mentioned. All the chloride goes into the bloodstream, and the bicarb then says, okay, you're here now. I'm going to go inside the cells. And now what's the pH situation in the bloodstream now? If the bicarb leaves, that's acidosis. Right? So when your pH is low, that's one of the triggers for SNS, right? So SNS response, right? We have metabolic acidosis. So DKA, we'll learn today, you have these specific findings for DKA, Kussmaul breathing, 3 Ps. We'll talk about those things. Lactate, it's an infection, usually is the most common reason. So they can probably have a fever, right? It can get severe enough and cause hypotension, but all these things cause a rise in lactate, and those things itself can cause lactate to go up too. And then diarrhea. So we talked about that. If they have diarrhea, they can be at risk for dehydration, right? They have a risk for, and they'll have an SS response as well. And renal failure, we'll talk about renal failure symptoms when we talk about renal, but just to note that renal failure usually equals hyperkalemia, and that puts you at risk for what ABG imbalance? Metabolic acidosis, right? All right, so what's the fix? Underlying cause. Don't give sodium chloride. Make them stop having diarrhea. Make them have, fix their ketones. Fix their lactate, right? How do you fix someone's lactate? You can, A, fix the oxygen level, fix the blood pressure, or probably if they have an infection, you're going to fix the infection with antibiotics and such, right? Fixing DKA, you're going to learn today how to fix DKA, and that's FIE, fluids, insulin, electrolytes, right? So those are all the fixes for someone that needs, that has metabolic acidosis. Someone's hyperkalemic, give them a potassium cocktail, right? It's like a cocktail hour now, it's happy hour. All right, and then the piece that you have to be alert for is that, again, when you're acidotic, you get to the point where your medulla no longer functions, and you can start getting, not having SNS response anymore. You can start getting bradycardic and stop breathing, and now you have respiratory acidosis on top of metabolic acidosis. That's 2 acidoses. That's not good. That's usually not survivable. Okay, last piece is alkalosis, metabolic alkalosis. So that means you're gaining or losing bicarb. You're gaining bicarb. Why would you gain bicarb? Because you bought it at CVS at 2 in the morning because you had heartburn. You're like, I'm done with this, right? And you ate all of the bicarb tablets, right? That can do it. Take too many antacids. But in the hospital setting, usually it's a bicarb infusion, right? That goes unchecked, and also a diuretics. I didn't put diuretics there, but also you get hypokalemia, also due to diuretics, right? And then the other piece is loss of acids. Right? Loss of acids, yeah. So you're losing acids, so the hydrogen ions are leaving, and you're left with what? Bicarbs. Let's add diuretics there.
It's down there, it's just not.
I didn't put it on. Oh, okay. It is there. Okay. So yeah, so we have diuretics, and that causes a contraction alkalosis, a metabolic alkalosis. What are the symptoms? It's very, very non-specific. It's not really, you can't say, oh, they got metabolic alkalosis. It's not very easy to tell when someone has it because none of these things trigger an SNS response, right? So it's not as easy to catch. They could breathe slow in some situations if it's really, but really it's very non-specific. Okay, so how do you fix all these things? Underlying cause. If they're vomiting hydrochloric acid, you tell them to stop, right? Or you tell them to you give them antiemetics. Antiemetics equals what prolongation? QTC prolongation, right? So what's another way, fast-acting way you can, if you don't have an order for antiemetics, how can you stop someone from vomiting? Well, alcohol pad. Everybody has an alcohol pad in their pocket. Pull it out. It's going to make you stop vomiting. You can do it for yourself too. You put an alcohol pad in your mask when you change to stage 4 decubitus. You're not going to vomit. Okay. All right. If they have low potassium, which causes metabolic alkalosis, you got to replace the potassium. How do you replace potassium? Slow or not fast, right? Depends if they have a peripheral IV or a central line, right? And then if they still need diuretics and they're still alkalotic and diuretics cause the alkalosis, you can give acetazolamide to acidify the blood, okay? So that's the idea there's a summary of all of the things we've been talking about.